Good morning, everybody. We're very glad you're here. Thank you for coming to this beautiful facility. We have so much information to share with you today. So we're going to be talking mainly about palliative care, what it is, what it isn't, how to access it, and when it's appropriate, in medical terms, when it's appropriate. To give you a little background on myself, I am with Pathways Hospice and Palliative Care. We are actually the hospice and palliative care component of the Delmar Gardens family. So most people don't know that Delmar Gardens has a whole list of ancillary companies that support their nursing facilities and support the community in general. So we have our Pathways Hospice and Palliative Care. We have skilled home care and private duty home care. We have a medical equipment company that's called Med Resources. We have a pharmacy, and we have a wound management company. So we provide those services within the Delmar Garden facilities, but also, and more importantly for you all, we provide these services in the community. So we come to your home wherever you live, wherever you call home, whether it is an independent living, a retirement community, or your own private residence. These services all come to you. And then we also provide these services in the Delmar Gardens family. Pathways has been around for over 30 years. As you know, Delmar Gardens just celebrated their 60th anniversary. So they've been around in our community for a long time. I've been with Pathways for 18 years. I've watched our palliative program grow. I've seen the challenges of educating in the community about palliative care and therefore getting palliative care into the homes of the people who need it the most. So we really feel passionate about education, and we're so thrilled that Ted had the foresight to think to bring this topic to his Senior Learning Institute. So we're really happy to be here. I'm going to go ahead and get started on our slides. Feel free to ask questions at any time. If you'd like, you can save some questions to the end. I'm fine, whatever you feel comfortable doing. If you have a question in the moment that you want the answer to right away, just let me know. So we're going to be talking about how palliative care improves quality of life. And that is really the goal of both hospice and palliative care. And just to touch on that subject, I did give you a handout that is the difference between, just to know that we'll be touching on some of those topics here. So what is palliative care? Palliative care is very specialized medical care. It is for people who are living with a serious illness. But what is considered a serious illness? We're going to go over some of the details of what that looks like. But a serious illness is an illness that creates a life-limiting situation for the patient versus a terminal care situation. So somebody on hospice care has a terminal illness that there's no cure for. With palliative care, it starts very early, and it is when someone is still receiving aggressive treatment. So that's the beauty of that, is that we're coming in very, very early to alleviate symptoms. So this type of care is focused on providing relief from the symptoms and stress of a serious illness. When someone is living with a serious illness, whether it is heart disease, lung disease, Parkinson's, dementia and various Alzheimer's, cancer, ALS, all of those types of diseases are life-limiting. You can live for a long time with them, but they are likely going to end your life sooner than if you didn't have Parkinson's or if you didn't have advanced heart disease. So it's not terminal, but it is life-limiting in the end. And so we want to make sure we're coming in and addressing the symptoms and the stress of living with those symptoms very, very early in the disease trajectory. The goal is to improve quality of life for both the patient and the family. And that is something that is unique to palliative care, and it's unique to hospice. So palliative care is coming in, and we are bringing the whole family into the picture and bringing them around the table to have conversations about goals for care and including the patient in those conversations. So many times when you go to see a physician or you're going to see a specialist, they are focusing on that disease that they're treating. And you're in and out very quickly. Palliative care comes in and spends as much time as is needed with the patient and the family to make sure that we're talking about goals for care, symptom management, pain management on a daily basis. How can we help the daily quality of life when someone is living with a serious illness? Hi there. So some synonyms for palliative, and I wanted to make a slide for this, and I'll probably do this for the next time, is how you pronounce the word palliative, because we always say there's no Y in palliative, because many people say palliative instead of palliative. There's 2 L's and you pronounce both the L's. So one of these times I'm going to put that pronunciation up there. So what are synonyms to palliative? To palliate. What does it mean to palliate? To soothe, to calm, and to alleviate. So when we're talking about symptom management, we're trying to soothe, calm, and alleviate the symptoms that are alongside that disease. And palliative care is kind of an umbrella term. It does include hospice only because hospice and palliative care both focus on comfort. But they're doing this at very different ends of the disease process, but focusing on comfort is really the main goal. And isn't that what we all want, right? And do we have these conversations in the physician's office? Probably not as often. They're giving you medications, for symptoms, but it's not as in-depth it is when you have someone coming into your home and having these conversations with you in your own home setting, where they can take as much time as is needed for each patient and family. So what are the similarities to hospice and palliative care? Because most people these days are starting to confuse the two. So and we've been doing palliative care for about, I've been with Pathways for 18 years, about 15 years. We were the first agency to provide this level of care outside of a hospital system. So most of the hospitals have a palliative care medicine department. They have a physician and they have nurse practitioners for those patients who are receiving care within their 4 walls. Most are not providing care outside of that setting. At least they weren't until a few years ago. They're starting to now. But we were the first to do that outside of that setting because we recognized that need that was not being met in the general community. But now we're starting to see, people equate hospice with the last 24 hours of life. And they're starting to confuse palliative care with hospice care, unfortunately. And they're like, oh, well, that's hospice care. When in fact, they're very, very different. So we're going to go over the similarities, and you have some of the differences there in front of you as well. So care is for the patient suffering from chronic incurable illness. So in palliative care, we talked about terminal versus life-limiting, but life-limiting can still be incurable because we know that most terminal diseases start as a life-limiting disease. So if you've got COPD, so you've got lung disease, and it first starts out, you're getting a lot of treatment for that, but we know the trajectory is eventually, years down the line, it is going to become more of a situation where it's more serious than it is in the beginning. So it's care for suffering from a chronic incurable illness, focuses on a comfort-driven plan of care. The aim is to provide holistic care. And that is something we're starting to see more of, fortunately, in our medical community, but it wasn't something we saw for a real long time. So holistic care is taking care of the whole family unit, from your physical care, spiritual care, emotional care. So holistic care encompasses all of those things. They don't just focus on the disease process of that person. They're focusing on the big picture. Both use a multidisciplinary approach. So they're going to have their clinical team, but they're also going to have their supportive team of their social worker, their chaplain, and their volunteer. And we'll go over some of those details also in a little while. Quality of life is the priority of the care. It does require a physician's order, and it does require permission from the patient and family. So we're coming in and we're operating under the orders of a physician. It can be the patient's primary care physician. It can be also the patient's, if they've got a specialty physician that they go to, such as a cardiologist. And then palliative care and hospice also have their own medical director who specialize in pain management. So many times we'll see the primary care physician will defer pain management decisions to the medical director of the hospice and palliative care agency, because that physician really specializes in pain medicine. And a lot of the primary care physicians will say, I'm going to defer to that specialist, just like they would defer to the cardiologist or they would defer to the nephrologist. But it does require a physician's order. So there's nobody operating rogue without collaborating with the physician. We're going to have a little competition next door, I think. So some of the differences, I'm not going to go over all of these because they're on your sheet, but a couple ones that I do like to point out, that palliative care is appropriate at any stage of a life-limiting illness. You don't start hospice care until there's a prognosis of 6 months or less. So palliative care is starting very early when there's a serious illness, but it's not a terminal illness. We're treating that disease process with success, right? We're treating that disease process. We're seeing positive outcomes from whatever treatments we're doing, the medications we're doing, whatever we're doing. We're seeing some positive progress from that, and that's when you're starting palliative care. They both must have medical necessity. Another big one is that with palliative care, you're still receiving aggressive treatment. So you can still go back to the hospital for whatever you might need or choose to do. With hospice care, you're choosing to forego those curative treatments because you found that those curative treatments are no longer helpful. So in this situation, we talk about benefit versus burden. So if someone is receiving aggressive treatment, whether it's physical therapy, maybe dialysis, maybe chemotherapy, that's considered aggressive curative treatments because we're still in a curative mode. So with palliative care, you're still pursuing all of those curative types of treatments because they're helping. So benefit versus burden. When the benefit of those treatments, when the benefit of dialysis is greater than the burden of going to dialysis and getting the treatments, you're going to continue to do that because there's benefit in getting those treatments. When the disease gets to the point where the burden of that treatment is outweighing the benefit, where we're seeing that the chemotherapy is no longer being effective, we're seeing that the dialysis is no longer helpful, and we're seeing that the patient is having a harder and harder time even just physically getting there. And you're hearing statements like, I'm so tired. I really don't want to go today. Or I really don't want to go back to the hospital again. Those repeat hospitalizations. We need to start paying attention to that. And we need to know that the burden of those treatments is outweighing the benefit. And we want to start looking at a different type of care. If those curative treatments aren't helping and they're providing more burden, then let's go to a strictly comfort level of care and keep that person comfortable with the best quality of life that they have left. So that's a big difference between palliative care and hospice care, is the benefit versus burden factor. And we feel like that's kind of a good way to explain that because most people can relate to that. So the focus of care, again, hospice is you're foregoing aggressive or curative treatment. Palliative care, you're focusing on symptom management, but the patient can still receive those curative treatments. Because again, the benefit is outweighing the burden of those treatments. So one of the things that palliative care focuses on is goals for care discussions with the patient and family. You want to be having these conversations very early. It's sort of akin to having our advanced directives done. You know, we hope that everyone is getting their, they say everyone over the age of 18 technically should have an advanced directive. Because if they were in a car accident or they developed a disease or something unforeseen happened, they want their family to know what's important to them. And an 18-year-old might not have shared that, but I found that that generation, because my kids are that generation, I have found that that generation actually is more open to those conversations than our elderly population is. Because, and in my parents' generation, and my mom passed away 11 years ago, thankfully, on our palliative care and hospice program, it was much harder to have those conversations because things weren't talked about in that generation. You know, things really weren't talked about. And the generation coming up, they're so connected with social media. They're so connected with the world and their feelings. And, you know, we've been more open to mental health. That generation is much more open to having those conversations. And so we want to make sure that we're including them in this as well, because they do have thoughts about that and they'll tell us. And that's the greatest gift that we can give to our family. No matter what age we are, the greatest gift we can give to our family is having our advanced directives in place and having these conversations. So here's a few conversation starters. These are things that our nurse practitioner uses and that you can also use with your own families. What do you know about you or your loved one's condition? What is most important to you regarding your treatment or your loved one's treatment? What do you know about the benefits and burdens of treatment? What is your wish for yourself or your loved one if no cure is available? If we really think about that, we need to give that serious thought and discernment for our own person. What is our wish if we have an incurable illness? Let's talk about that and think about that much earlier in that disease process than when we've elected hospice, which we usually elect hospice much later than we should. So we need to have those thoughts early. From what you know, do you think that over the next month, you or your loved one's condition will get better, will get worse, or will stay the same? So one of the things we talk about in facilities that we work with is we want families, but we want the staff also to be thinking about who in your community are you the most worried about? Who do you worry about of what's going to happen in the next 6 months and a year? Because most family members have been watching kind of a slow decline or maybe symptoms getting worse, those worsening symptoms that we see. Those are the things that we want to be paying attention to, because that's when we want to start thinking about palliative care. You can start palliative care at the onset of a diagnosis. When somebody is newly diseased with liver disease or kidney disease, and they're going to start dialysis. When they get a new diagnosis, that's the perfect time to start palliative care, because you need to have the conversations then. When it's fresh and they can think clearly before they get to the point where maybe medication is kicking in and maybe their thoughts aren't as clear. So we really want to do that early. And then we see this a lot. You seem surprised to learn how sick your loved one is. Most of us are in denial when it comes to ourselves or our loved ones. And I will tell you, like I said, my mom was on our program. She died 11 years ago at the age of 92. She was a very robust senior until she fell when she was about 90 years old. And she had this slow decline from that point on. But I, at that point, had worked in hospice for many years. But I was so close to it that I couldn't see it. And I was really fortunate to be surrounded by such wonderful nurses and social workers. And they're like, well, let's talk about this, because they were coming in to see her through palliative care. And it was the most beautiful thing, because they opened my eyes to something that I couldn't see because it was too close to me. And then afterwards, I was like, how did I not see that? Because we're too close. And that's why we need someone else to come in and help us in a really loving way to see what's happening so that we can do the most good for that person. Because that's really what we want. All of us really want the best for our loved ones. So one of the things that we talk about a lot in palliative care and hospice care is, what is quality of life? Well, Pew Research did a study and they identified the top answers for most adults. So quality of life for most adults means being able to talk or communicate in some way. We can communicate in ways other than speech. Being able to feed oneself, getting enjoyment out of life, living without severe lasting pain, feeling that what one does is worthwhile. And when you have a team of experts coming in, they really help to bring in other resources to make sure that all of those important answers are being addressed. And sometimes families just are at a loss and they're overwhelmed and they can't think through all of those things. Sometimes you just need somebody else to come in and kind of go over that. So where can I get palliative care? It is much more accessible now than it was when we started it 15 years ago, thankfully. In a hospital setting, in an outpatient clinic, the VA clinic has a really wonderful outpatient palliative care program. Independent living communities, assisted living communities, skilled nursing facilities, and a private residence or wherever you call home. So just like hospice care, palliative care comes to you wherever you or your loved one resides. And most people think that it's a place you go, when in fact it actually isn't, and it comes to you. There are a couple hospice houses in St. Louis. There's DeGraff House and there's Evelyn's House. There's a new one starting up out in St. Charles as well, right? I think it's Solace. I think it's starting that. It's much needed. Each of these facilities are rather small and they have a long waiting list. So we need more of that in our community, because a lot of people do choose to not be at home, but they might not want to be in a skilled nursing facility, but they might want to go to a hospice house. So, which is very different than palliative care, but just kind of wanted to throw that out there. So who is on the palliative care team? Who comes in to provide services, and what exactly do they do when they come in? So we'll cover that one next. So you've got the palliative care physician, the nurse practitioner, which, by the way, if you think about it, that's a very high level of care coming into someone's home. How often do you get an NP or a physician coming in? So very high level of care. There's a registered nurse also that is collaborating with them. And then any other services that that provider offers. So there's several palliative care providers in St. Louis. Like I said, we've been doing it the longest. A couple of the providers have pulled out of the market, so there's really only a handful of us left that are doing it outside of the hospital system. But the other services that we offer is we pull in our chaplain, our social worker from our hospice program, a dietitian, physical therapy, volunteers, and healing therapies. So healing therapies include things like massage therapy is a really wonderful healing therapy. It is amazing from a medical perspective what massage therapy can do. And it's different than going to Massage Luxe or Massage Envy and having, a spa treatment. This is focused on medical needs. So somebody that has a lot of edema, maybe from heart disease, that becomes very uncomfortable and very heavy for them. And so massage therapy can actually work that out and give them a much better quality of life. And so those are the comfort measures that are pulled in our palliative care program. And that also is something that's pretty hard to find coming into your home. And again, all of these services are offered when there is a medical need. So we'll go over that in a minute as well. What exactly does the physician and the nurse practitioner do when they come into the home? So they're going to, and they are, like I said, a very high level of a practitioner, of a medical practitioner operating right underneath of a physician. They will do a full history and physical assessment of the patient. They will do a pain and symptom management evaluation. So they'll determine where they are on the pain scale and what their symptoms are, and looking at how we can alleviate those symptoms. Sometimes it's switching up medications. Sometimes it's taking away some medications that they might not need any longer, that have a lot of side effects, that they just have been taking forever and ever and ever. And we just think, well, the doctor said I should take these, so I'm going to keep taking them until the doctor tells me I don't need to take them. But the doctor's probably not going to take a medicine away. But we can come in and discern that a little bit and see if that might be helpful. Not always, but it might be helpful. They function typically in a consultative role where the patient's primary care physician and or the palliative care medical director is overseeing all of the care. The nurse practitioner has the eyes on the patient. They are at the bedside, but they're collaborating with the medical director and or the patient's primary care physician. So one of the things that we say about palliative care that I think describes it so well, palliative care ties it all together. They put all these pieces of this puzzle together and they tie it all together, and they can just sort of synchronize all of that, work with the different physicians, and make a very simple plan of care that makes sense and provides comfort for that patient while we are respecting their goals for what's important to them. There's a lot of pieces to that puzzle. And when you just go to the doctor's office, whether it's your PCP or a cardiologist, they're looking at one little piece of that puzzle. But palliative care pulls all that together because we collaborate with all of the physicians. So we collaborate with the primary care physician, the specialty physicians, and it's sort of like they can pull all the weeds aside, figure out what's going on, and come up with a plan of care. And that is something that's very unique and hard to find. They focus a lot on advanced care planning. That is a very important part of this process, because if families don't know the wishes of their loved ones, they can't honor their wishes if they don't know what their wishes are. And most families will tell you, well, we just really want mom or dad to be comfortable. Whatever's important to them, that's what we want. But sometimes they've never had those conversations because it's hard to talk about. And sometimes in some generations, they don't want to talk about that. But palliative care can come in and facilitate that and get everybody on the same page. So advanced care planning is a big part of what they do. They do a patient and family interview. They talk about healthcare choices to ensure that the goals for care are respected. What's most important is what is important to that patient. That kind of falls in line with a philosophy of care that hospice and palliative care both subscribe to, which is the level of pain for that patient is whatever that patient says it is. So if we have a patient and they say that their level of pain is a 10, We're going to be collaborating with everyone, but we're not going to say, well, it's not really a 10, we think it's probably a 5. You have to go with whatever the pain the patient says they're in, whatever that number is to them. That is what is real to them. Their perception is their reality. And people say, oh, they always say that. Oh, they're always, well, there's some reason why they have agitation about that. So it might not be that, the pain might be that they're uncomfortable in their wheelchair, but they're uncomfortable. But we have to take the time to figure out what that is and not dismiss it. And if they say they're in pain, we have to address that pain and figure out the root cause of that pain. We know there's such a thing with amputees where they call it phantom pain, but you still treat them for that pain and you don't dismiss it and say, oh, but you don't have a leg, so you're not in pain. That's not helpful to them. Their pain is real to them. Their symptoms are real to them, so we're going to treat that accordingly. And then medication reconciliation. There's a term that we use a lot in the industry called polypharmacy. So we know that so many people in our community are seeing multiple physicians, and all those physicians are prescribing medications. And some of the medications they're prescribing are to offset the side effects of another medication that another doctor prescribed. So medication reconciliation doesn't mean coming in and setting up pill boxes and making sure they're taking their medication. It's going deeper from a more clinical perspective of all the medications that they're taking, why they're taking them, what is really helping, what things are negating other things, what can we alleviate for them. Sometimes people have pill burden. Some people wake up in the morning and they take 20 pills, and they've just been taking those pills forever. And nobody's ever questioned it. The doctor's never mentioned it. But we need to look deeper because sometimes we can alleviate some symptoms that are caused from some of those medications that we might have a better system for. So that's one of the things that their expert eyes can look at. I'm kind of trying to pay attention to the time here too. The conversations for advanced care planning, as I said, is a big part of what we do. What's most important to you right now? What are your goals? And the nurse practitioner will ask, what do you need or what can I do to help you accomplish your goals? Sometimes it takes that third party coming in to get everybody around the table to have those conversations. Because it's like having a physician come in and suddenly they're going to listen to that medical expert, right? That maybe families weren't able to really have a good conversation about or be on the same page for. They can kind of come in as the third party. And then they answer those questions, will guide the conversation that the nurse practitioner is having with the family. So a little quote by Patch Adams, it's one of our favorites. You treat a disease, you win or you lose. You treat a person, I guarantee you'll win, no matter what the outcome. And that's what we're doing is we're treating a person. We're treating a whole person. We're not just treating their disease. We're treating the whole person. So who would benefit from palliative care? Anyone that has a chronic life-limiting illness at any stage. So CHF, COPD, we talked about all of these already. Age-related frailty is a big one. We have some folks living at home that just, their health really isn't that bad, but they're just frail, elderly folks. And they need some attention, and we need to make sure that we're honoring their wishes for what their trajectory looks like as they're aging and changing. If there's any unrelieved symptoms, so such as pain, shortness of breath, edema, that's one of the things we talked about with having massage therapy come in, edema or weight gain. So those are some typical symptoms that we see that we're able to come in and alleviate. Showing signs of general decline, the worsening weakness, the loss of appetite. Frequent ER visits, that's a big one because so many hospitalizations are unnecessary. And when you have services coming into your home, many times they can prevent those unnecessary rehospitalizations that many times we see our frail elderly coming out of the hospital actually feeling worse. It's harder on them every time they go. And we'll actually hear some folks will say, I don't want to go back anymore. Do I have to go? I don't want to go again. It's so hard on them, right, to go. So frequent ER visits is kind of a red flag that somebody might be benefit. If they need support making decisions regarding future care. Those who don't yet qualify or aren't ready to elect hospice services. So we know that these life-limiting illnesses, over time, there's a different time trajectory for each person of each illness. But we know that terminal illnesses start out as a life-limiting illness. So there's a diagnosis of COPD. It might be manageable for years and years. Eventually, it was going to get to the point where it becomes a terminal illness, and so that's when hospice comes in. But we want to start palliative care over here when it's first diagnosed, when there's new symptoms, when there's shortness of breath that they're trying to manage. Maybe the shortness of breath is starting to get a little bit worse. So what do we need to do to address that? So that's who is appropriate. So the benefits to patients and families, provides pain and symptom management, quality of life, many of the things that we talked about on here. The one that is, the two at the bottom, I think are really important to mention. An additional layer of support for the patient, the family, the healthcare workers, and the caregivers. So somebody might have private duty services coming into their home, an extra layer of care. But they also need support. Many of them also need education from a more expertise level regarding what's happening with that particular patient. Providing coping strategies for living with a chronic illness that is life-limiting. As we mentioned earlier, the symptoms and stress. For someone who is short of breath, it is stressful to be short of breath. It's stressful to be short of breath every day to walk across the room. They may be very functional, they may be able to do the things they need to do, but it's stressful on them. And as we see that getting a little worse, it becomes more stressful. So how can we go in and alleviate that and make sure that they have good comfort systems in place? Navigating healthcare goals. It's so overwhelming for patients and families to navigate that. Ongoing education about the disease process and the prognosis. I know there's a lot of resources online now, but I think it sometimes can be overwhelming to just Google CHF, because you are going to get, a million responses. You need to make sure that you're verifying who the source is of the article that you're reading. You want it to be like Cleveland Clinic, Mayo Clinic. You don't want it to be something that's not reliable. So just navigating that can be overwhelming when the caregiver's already trying to provide care, and then they're trying to navigate that. So that's why it helps to have a professional come in. The interdisciplinary team cannot be understated. That is so important for quality of life. It really does take a team. I love the quote, it takes a village, right? In healthcare it does, it takes a team. And it takes a skilled team to come in and do that. How is palliative care paid for? That is one of the biggest questions that we get. We know that Medicare is covered under, the hospice is covered under Medicare Part A. For palliative care visits that are outside of a hospital system, which is what we're talking about today, visits are paid for like a physician's visit. So the nurse practitioner is coming in a consultative role. So he or she is not coming in every other day, every 3 days. They're coming in when there's a medical need, when there's a medical necessity. And that's kind of key in this situation because it's billed under Medicare Part B or your insurance as if it's a specialty visit. So, sometimes if someone is going to see a specialist, they'll have a copay for their primary care physician, but they might have a higher copay when they go to see a specialist. I know that's the case in our insurance. If we go to see a specialist, it costs a little bit more. So there could be a copay for private insurances or for the Medicare Advantage plans, which we know are really popular right now. So there might be some copays and deductibles that might apply for palliative care that usually don't apply in hospice care. But we have a billing department and they flush all of that out and they will know what is covered and what isn't covered. And we come back to the family and we say, this is what your insurance is telling us. There's a $40 copay or you've got unlimited visits or whatever the case may be. But it's a consultative visit similar to going to see a specialist. So sometimes in palliative care, there's a copay. But people will know that ahead of time. Who can make a palliative care referral? Because it's like, how do I get this? How do I get palliative care for someone? Well, anybody can make a referral. You will need a physician's order, can be from the primary care physician or the specialist. Discuss it with the patient and family. It always should be discussed. We're never coming in without the approval of the patient and or the family. So that is very important. Everyone needs to be on board with a plan of care. And just notify the palliative care provider. We have options there where you can just give us a call our office. We have an intake coordinator. Her name is Mariah. She has her master's in gerontology. She will answer any questions that you might have. Great resource. But anyone can make that referral and you can ask your physician for an order for palliative care. and say, you know, we're kind of looking at palliative care. We think that might be beneficial. And most physicians are going to go, oh yeah, that's a good idea. You should probably do that. You know, most physicians are not going to say, no, you shouldn't do that. Sometimes in hospice, physicians aren't quite on board when it's hospice care because they kind of feel like they're giving up on that patient or they want to maintain that control. Palliative care is kind of a different scheme. So most providers are going to say, yeah, go ahead and look into that. But we do need an order from the physician, and they're used to faxing orders over to the office, so that's never an issue. So another quote that we like, to cure sometimes, to relieve often, to comfort always. And that is the goal. And I think that as we are becoming more educated consumers about our own healthcare and the world in general, we can feel more empowered to ask for the services that we think are going to be beneficial. We need to be empowered and knowledgeable to ask for these services because sometimes the doctors aren't thinking of that, but it could be really, really beneficial. And then here are a few resources. If you want to take a picture of that or write them down, feel free to do that. I highly recommend getpalliativecare.org. It is a wealth of information, an absolute wealth of information. CAPC is all about palliative care. That's another good one. The Conversation Project is tools and tips for how to have conversations with your family. And most of us need some guidance in that, even just to bring it up for the first time. Like the next time you're going to the doctor, maybe we should ask about palliative care. Just having that conversation, right? And so that gives you, that's a very grassroots organization. Started many years ago. It's highly respected. And they have a lot of information on their website about, you know, how to bring up these topics with your family, how to talk about these topics with your family. Some of those are really, really helpful. And I had a couple things here that I wanted to touch on that I want to make sure I don't forget. Hang on one second here. I think the first one was one of them that was really important that I thought was good. How do I know if palliative care is right for me? So even though we've gone over all these things, it's still good to kind of drill this down just a little bit. Palliative care may be right for you if you have a serious illness, including but not limiting to the ones that we mentioned before. Palliative care is appropriate at any stage of the serious illness, and that's what's important to remember, at any stage. And you can have this type of care at the same time that you can have curative treatments that are important to you. So that is something that is hard to find as well, is still having something that you can still get those other treatments. You don't have to forego any of those treatments. That's why it's important to make these referrals early, and that's why we feel it's so important to educate about this, because people really don't know and don't know where to begin. But there's a lot of resources out there, and our office can be a good resource for you as well. Does anybody have any questions or anything I didn't cover? Oh, okay. Ted might give you the microphone. He doesn't want the microphone. You can ask me after if you'd like. Yes, okay, that'd be fine. Yep, that would be fine. You can ask me after, absolutely. Okay, any other thoughts? Any other questions? Ted, you had some great thoughts last time.
You find that people are not taking advantage of it early, similar to hospice?
Yes, and they're not taking advantage of it early enough. Hospice is the same. They don't take advantage of that early enough, and they don't take advantage of palliative care early enough. A lot of it is because they just don't know about it, and they're thinking that it's too soon. Oh, I have to wait till I'm sicker, right, to get that level of care. But it's designed to be provided early. Does that help?
Yeah, it does. And the conversation project that you had mentioned really comes into play because it's hard to have that conversation. I've got somebody in my life right now who could benefit from this, but wouldn't even want to consider having the conversation, even though it could be helpful.
Right. And the Conversation Project has a lot of tips for how to do that because it's challenging for everyone. So that's a great resource.
It is. And how do you, the family dynamic, because you had mentioned you might have 3 or 4 siblings that are trying to help mom, but not everybody's on the same page. How do you have that conversation so that you can maybe sway one or the other to be a little bit more proactive?
And that's where our skilled nurse practitioners come into play, because they have specialized training in having these conversations and having them in a really loving yet firm way. And honestly, not everyone is going to be on the same page. We know there's family dynamics in every family. But I think that what we've seen is that in most of the cases, if not all of the cases, you can at least get them to the point that they will listen if they know that this is what's important to their loved one. Because at the end of the day, what the folks that are not on the same page really want is whatever is best for their loved one. And they love them, and they really do just want them to be comfortable. They just have their own barriers about that. So if we can break that down a little bit for them, they might not engage terribly in it, but they'll at least be open to letting it happen. And that just takes a few visits to be able to do that.
It seems like the physician is really, really key as a gatekeeper here to help folks understand that this is an option for them, and because they're an authority figure, and oftentimes they will listen to their physician or someone who has a badge on versus a child.
Yes, and that's why it's helpful to have a nurse practitioner come in. They come in with their lab coat, they come in with their credentials, and they're collaborating with the physician. So they can be the go-between for the physician. But they also, it's when you have a third party come in, it's a game changer, because it's similar to the physician. Or suddenly it's someone else, and they're gonna pay attention and listen to them and go, I wonder what do they have to say about that? Because they are coming in as the expert, as they are. They're experts in this, and they have special training in it. So many times that's what's helpful.
Right, and you would hope the in-home care companies would also jump on the bandwagon as well and
Yes.
make the recommendation, the suggestion
Yes.
that they look into that.
Because we do work with skilled home care companies, because palliative care can be providing care at the same time as a skilled home care visit. Whereas hospice and they can't do the same. Hospice can't come in when it's skilled because it's both billed the same. And so Medicare won't allow that, because they won't allow that double billing. But palliative care can come in at the same time as skilled nursing care in the home, which is beautiful.
So I can see the liaison with the skill, but also the companion care companies as well.
Oh, absolutely. Absolutely. We work with a lot of them in St. Louis. We partner with a lot of them in St. Louis. And a few of them are starting to provide their staff with specialized training for someone that has a life-limiting illness. And so we've actually gone in and done training for the private duty companies, for their staff, to talk about palliative care and hospice care so that they have a better understanding. Yeah.
Thank you. Any other questions?
One back there.
Yeah, you kind of mentioned on the skilled care versus maybe palliative care.
Mm-hmm.
Can you kind of explain that a little bit more?
Can you say the beginning of that again?
He mentioned skilled care coming in,
Yes.
and maybe versus palliative care.
Uh-huh.
Can you explain maybe the difference in those two, or who makes that call? Or
Yes, yes. So for skilled nursing care in the home, the terms get interchanged. And so there's private duty care and there's home care. So home care is skilled care. It's a registered nurse coming in. It's physical therapy coming into the home, providing a higher level of care, versus private duty companies are providing more custodial care. So they're doing some personal care. They might be helping with laundry. They might be staying with the patient so that the caregiver can go to the doctor or do some errands. But it's an unskilled level of care. It's considered custodial care, and some private care is involved in that. Skilled home care is where it's a higher level of need. So you have registered nurses coming in, and they also have aides that come in and physical therapists that come in. So for palliative care, because under the palliative care umbrella, you can still receive aggressive treatment, and skilled home care is considered curative or aggressive treatment. We can come in at the same time. Hospice care, you can't do that, because hospice care, you're foregoing those curative or aggressive treatments that skilled home care is providing. And again, it's that benefit versus burden that we like to refer to. But that's why palliative care can come in, because it's early in the disease process. So they're still pursuing curative treatment, and they're doing more aggressive, like physical therapy is considered curative and aggressive treatment. So does that answer that question better? I hope so. It is hard to understand and describe. Any other thoughts or questions?
Yeah,
Anything you want me to address?
I'll say to elaborate on that, so the skilled, let's say mom comes home from rehab and they follow up with her once a month, maybe twice a month, or there's wound care or something along those lines. You have a skilled home care company that's coming in to take care of that medical side of things. But then if mom's all alone, but needs additional support in the house, that's where private duty comes into place. It's companion care, meal preparation, companion care, transportation to doctor's offices, things along those lines. So apples and oranges. Whereas, so private duty, companion care is mostly always private pay at $30, $40 an hour nowadays. Whereas the skilled care that's coming in is typically covered under Medicare.
Because Medicare covers those types of skilled services, but they don't cover custodial care or someone just sitting with someone and providing companionship. Medicare doesn't cover that because it's not skilled in their eyes, so.
Got it.
Yeah.
Okay. Any other thoughts?
that's
Any other
helpful.
questions?
I might stick around after.
Oh,
All right,
absolutely.
good. All right, fair enough.
Absolutely.
All right, well, very good. Cheryl, thank you very much for
Thank
doing
you,
this.
Ted.
We appreciate that. You did a
Thank
great
you.
job. Appreciate it.
Thank you.
Thank you all for coming. Please give us your evaluations. We'd appreciate that. There's literature tables in the back, so feel free to go ahead and grab whatever you'd like off the literature table. Please check out the website, seniorlearninginstitute.com. There's a ton of information on a variety of different topics that touch older adults and their loved ones. Feel free to use, you don't have to register for it, just use it. Plenty of videos, plenty of links on there, so we'd appreciate you going to that, and then we'll see you next month. So thanks for coming.
Thank you.